So I was asked to give a presentation on a combined disease in a patient with both aortoiliac and common femoral disease. And for me, as a vascular surgeon, this is really the ideal candidate for a hybrid approach. So we'll review a couple of cases. I'll consider and discuss some of the decisions and leading to the approach I took and some of the outcomes for these patients. So the first is a 72-year-old female who actually came to me for a DVT management in my clinic. She's obese, poorly controlled diabetes. She was currently on Xarelto for the management of her DVT. She had a left leg swelling, and in this setting had a venous wound. She had already been on Xarelto for a month, so this wound was there for some time. She had a duplex showing a femoral popliteal DVT. And actually, when speaking with her, she told me her wound started about 2 months prior, starting with a blister in the posterior calf on the left. And additionally, after much trying to probe the history, she reported some foot pain and numbness as well. Ultimately, all of this took her out of her home, placed her in a nursing home for inability to take care of herself. She had described an intervention which I wasn't really quite understanding, but certainly was a poor historian, and on exam she had a pulseless left leg, so not just a venous problem, all the way from her groin to the foot. She had barely venous phase signals at the foot, some significant swelling, and otherwise had a normal right leg on exam. So here are some pictures of the patient. Clearly an atypical wound, not a typical venous wound, a very extensive, large wound. We had our vascular lab right next to the clinic, so I took her straight to the lab and got some non-invasive studies to confirm and document what my exam had a high suspicion for, which was an inflow problem. She had normal waveforms on the right and essentially was in critical limb ischemia on the left with no pulsatile waveform or decent waveform at the femoral level, and an ABI of 0.12. Given her history and unclear interventions at outside institutions, for a patient like this, my approach is to get a CTA if I have the luxury and the time to do so. We got her a CTA within 24 hours prior to admitting her to the hospital for additional intervention. Here are some cuts of her CTA. This is a picture of her iliac bifurcation. There's some disease, but another otherwise open proximal part of the common iliac artery. This was, what wasn't very clear on the story, which was she had had a previous left common iliac stent, which was obviously occluded. This went down to the level of the hypogastric artery, and she reconstituted to a very distal external iliac artery just above the circumflex vessels, and what appeared, could be interpreted as some common femoral artery disease versus an underperfused vessel. So for a patient like this, first I'd like to assess what the problem is. To me, she had something that's not very typical. She had an inflow problem stemming from her certainly iliac disease and possibly a common femoral disease. And I think the wound progressed so quickly because she had, and it was atypical because she also had an outflow problem. So we have a patient with both CLI and DVT. For me, the goals was to heal a high calf wound and get her out of rest pain. So I was going to focus on her inflow disease. She also did have some popliteal occlusive disease. So when I think about a patient like this, I try to think of what the best approach is to give me the best success. So when I thought about her, just based on CTA imaging alone prior to any angiography, I thought, well, we can certainly take her to the operating room, go through a left groin approach, do an endarterectomy, patch angioplasty, and attempt a retrograde iliac recanalization with a bailout procedure of an antegrade approach being the right groin or the left brachial. Or I can go straight from the right groin access, trying to cannulate that small proximal common iliac artery from an antegrade approach with intervention, and then take angiography to determine if my common femoral artery lesion is significant or not. Certainly a left brachial approach is a good option as an antegrade recanalization technique. Gets you out of the groin if there's a groin issue, and then similarly evaluate the common femoral and decide if you need to do a groin cut down to reconstruct that portion of it. And ultimately, if you think it's not an option to recanalize that iliac in your practice, a fem external anatomic bypass is an option, but certainly the least resort and something I haven't done since fellowship. So for this approach, I chose option B. And why did I do that? Really, it was mostly because of a device selection. I've had some success using this steerable device, which comes in 6.5 to 8.5 French internal diameter. It's the tour guide. It's a steerable sheath. It gives you the support when you have not a lot of purchase on the inflow side. It can steer up to 180 degrees, and you can rotate it right and left depending on which side you're working on. And so if it's a 7 French inner diameter that you're looking for, the outer diameter is about almost a 10 French, so that's something to consider when you're gaining access. Additionally, this patient had a groin folliculitis on the right side, so I wanted to stay away from that. I knew from my CT angiogram and from her waveforms that she had a normal superficial femoral artery, and I also wanted to have an angiography of the left common femoral artery before I committed her to an open groin approach and an open exploration on the left. So I did a small cut down over the superficial femoral artery to get this device up and over, and I knew that I would be fixing the superficial femoral artery with a couple of stitches on the way out. So to me, that was my safe approach. So here are some pictures showing what we came in, what we saw when we got in. So my sheath is coming in from the very proximal part of the superficial femoral artery. She had confirming the occluded left common iliac artery. Once I got my sheath up and over, I was able to get into this small nubbin of the proximal common iliac artery with this tour guide device, and able to get strong support by rotating that portion of the sheath to 180, almost 180 degrees. I was able to hook that part of the sheath, and then from there we were able to stay true lumen, stay within the stent, not go outside the stent, and using a combination of stiff glide, quick cross catheters, I was able to get down to the external iliac artery where she was back in true lumen and patent. And at this time, actually, what was a little bit surprising to me, truthfully, because I had her left groin all propped out, was that her disease was really not that significant at the common femoral artery level, and it was likely a combination of a little bit of posterior plaque on the CT and an underperfused vessel on CTA. So from this point forward, we proceeded with balloon angioplasty and placed cover stents into her, within the old stent, into the common iliac artery, into the external iliac artery, and balloon dilated that to a good common femoral and good profunda. So I stopped there. Again, for me, for this patient, my goal is to heal a proximal calf wound. This is an image and some pictures of comparing her pre-imaging vascular lab studies, the wound, and where she's at after about 6 months of therapy with continued therapy for her DVT and on antiplatelet therapy, and her wound is healing quite nicely. She's out of rest pain and she's doing well. So we will save the fem-pop lesion for later. Here's another patient, 65-year-old male with a history of a right external iliac artery stenting and right SFA stenting for short distance claudication. This was quite remote and he was doing very well. Recently, he had worsening left leg pain and symptoms, and actually, when you asked and probed him a little bit more, he actually was describing some early rest pain and paresthesias. He had undergone an angiography. Those are his medical history. He has mild chronic kidney disease, and this is his pre-op waveforms. So in an angiography, from a right groin approach, you could tell he had this was with the catheter slightly into the common iliac artery orifice, and there was a pretty dense calcified plaque of the common iliac artery orifice, an otherwise patent common iliac artery, and then very extensive, bulky, heavy calcific disease at the external iliac artery. Further look distally around the level of the femoral head here showed that there was heavy plaque burden, calcified disease at the common femoral artery, but really occlusive disease into profunda and the proximal part of the superficial femoral artery. Distally on the angiography, he did have some tandem lesions down the SFA, but an otherwise open SFA. The proximal part of the superficial femoral artery occlusion was about 2 to 3 centimeters based on CTA, and very heavy calcific disease. So for me, again, this was a patient who had worsening claudication and early rest pain, multi-level disease, and for me, again, a goal was to get inflow disease, given the heavy burden of calcium at the iliacs and the common femoral artery bifurcation. So lots of ways to think about this case, but for me, I really just had two. One was to approach the groin, do a left common femoral and extensive profundoplasty with reconstruction, and at that same time doing a retrograde iliac approach, and possibly go ahead and address the SFA at the same time, or do the extensive inflow procedure to the profunda iliac and then save the SFA for later. So I chose B, leaving the SFA for later, and actually did quite a bit of work in his groin and went up a couple of centimeters into the external iliac artery. So he essentially, from the groin, had a distal external iliac endarterectomy, common femoral endarterectomy, profundoplasty, reconstructed that, and I also did an endarterectomy into his SFA for about 2 to 3 centimeters and patchplastied that. This is kind of a picture depicting the extent of the patches and how they wide down to the common femoral artery bifurcation. Here's an image of pre-stent. So before I started my endarterectomy, we placed a microneedle up, got a microwire up, took a picture just to get me into a visual picture of what the true lumen looked like, and I was able to get my wire up, take a proper antegrade picture. Here's that heavy, bulky plaque at the common iliac level, extensive disease at the external iliac. Really, from the groin, there was no clampable vessel. If I had put a clamp in the external iliac above the circumflex vessels, we would have crushed his artery and really gotten ourselves into trouble. So for this approach, I do an over-the-wire Fogarty embolectomy for proximal occlusion, and this allows me to do a clampless inflow control while I do the endarterectomy. It also allows me to get my clamp up high into the external iliac artery and essentially do an eversion, almost an eversion endarterectomy of the external iliac artery about halfway up. We maintained our wire access through our patch and then proceeded with the iliac intervention. And at the end here is what we have. We have our stent up in the common iliac and a very extensive endarterectomy with continued stenting of the external iliac artery. Our patch angioplasty into an open profunda, and this is kind of the patch into the superficial femoral artery with some flow distal. So currently he's about a couple months out. He's doing quite well. He's on dual antiplatelet therapy and actually regained both pulses. His ABIs are near 0.9, and he is completely out of pain, so I think we'll save the SFA for later. So take-home points from a couple of these patients with both femoral and iliac disease is that for me, a CTA is a nice roadmap for both complex aortoiliac, multi-level disease patient, but certainly I make no plans until I get my angiography, and then I proceed with a final decision. After assessing the patient disease, focus on the goal you're trying to achieve for the patient, as you can always stage the patient with additional revascularizations down the road as needed. When the inflow problem extends into the groin, I think adopting a hybrid approach is a very good way to do this. When doing a hybrid procedure with a groin, open groin, consider a technique that will facilitate additional needed interventions down the line. So we say don't burn bridges, but this is almost like building a bridge for later. And so I do choose to get into the SFA a little bit when I need to. And then follow your patients closely post-intervention, and this way you will avoid less failures and limb loss, and surveillance is certainly a key in this paradigm. Thank you very much.